Good morning, everyone. Thanks so much for joining just a little bit early. Very excited to get started. If you don't mind opening up your chat box, saying hello, where you're logging in from. Can't wait to get started in just about 7 to 10 minutes. Looking forward to getting to know each and every one of you. All right, everyone, we're going to get started in just a little bit. Hope everybody can hear me. I would love to get to know each and every one of you. So if you don't mind going ahead, opening up your chat box, saying where you are logging in from, say a hello. We have over 50 people that are joining us so far. So really big classroom today. Super excited to kick off this new webinar series. Awesome. Sloan's here from Chicago. Kaylee's here from Virginia. Ahmad, Uday from India. Renee from Jamaica. Ali from Kenya. Dhruvi from India. Hello to my YouTube family as well. Rahul Raj from India has logged in. Excellent. We have Delayed from Naples, Pamela from New York, Linton from Florida, Paul from Dominicana, Ashmina from Atlanta. Excellent. Super excited to have each of you join. Again, if you're just joining us, feel free to open up your chat box, say hello, where you are logging in from. Make sure you're also putting away those distractions. This is going to be a full focus hour for all of us. Super engaging and high yield USMLE content. Going to get started in just about a few minutes. Thank you all for joining in. Really appreciate it. All right. Well, good morning, everyone. I hope you all can hear me and see me. If so, do you mind going ahead and typing in a yes into the chat box? Wonderful. Looks like many people can hear me and see me. Really, thank you all for joining today. I am very excited to get started with the brand new YouTube, Zoom, USMLE Step 1 series. And that is the Tutor with Me series. Today, we're going to be going through about a block of questions. And what I'm going to be doing is essentially taking a question and going through the test taking strategies behind the question. Before we get started, if you have not attended any of my webinars, I welcome you to the HyGuru family. And if this is your repeat webinar, thank you so much for sticking with me throughout this journey. My name is Rahul. I am a practicing pediatric critical care physician. I'm also getting my master's in medical education. And over the past 7 years or so, I've just been absolutely passionate about helping students just like you kick ass and excel on the USMLE. Feel free to connect with me along your journey. I'm really looking forward to getting to know each of you. So I know that there are many resources out there, but I just wanted to spend a couple minutes showing you what makes HyGuru just so unique. HyGuru is an evidence-based approach to USMLE preparation. And what I've tried to do is really base all of my content and lectures on active recall, because that is the true high yield way for long-term retention. I also like to integrate amongst concepts. And if you see a lot of my other YouTube videos, as well as join my courses, you will see that it's not just a cardiology lecture. I'll also be integrating various other organ systems and subdisciplines. And then finally, I think today's session is going to be a great representation of my passion for test taking strategy. And my goal by the end of today's session is for you to think like the test maker. So we hear about a lot of triads in our USMLE studies, but let me give you my triad for USMLE preparation. A couple of things I like to focus on. Number one, I like to focus on content integration. Number two, I like to focus on test taking strategy. I like to also advocate for productivity techniques and study scheduling. And if you join my test taking strategies course, you get a complimentary USMLE Step 1 study schedule made on Notion for you. And then finally, one of the things that I have noticed taking the exam myself and preparing with other students is that it is a mental grind. And I like to make sure that I'm optimistic, positive, make sure that I can give you some techniques to relieve that test taking anxiety. Most importantly, and we have about 80 students logging in so far, HyGuru is just one big family. And these are some pictures pre-pandemic from some of the classes which I would teach in across the country. And I'm super excited to have the opportunity now to create a virtual global community of learners. Today, we're going to be going through an overview, and I just want to share with you a very unique resource. Many of you are going into dedicated study or are preparing for your NBME and comp exams. And truly, from the bottom of my heart, I really feel like my USMLE Step 1 pass-fail course is a very efficient, comprehensive way for you to prepare for this exam. And I'm going to give details at the end of the webinar and do a live Q&A if you have any questions. But I do want to just share this very unique resource which I have created over the past few months. All right, but first, you all are here for a very unique session today, and that is going to be the Tutor with Me series. This is going to be block 1, and in subsequent sessions, we will be going through blocks 2, 3, and 4. But if you all are ready to get started now, go ahead and type in yes into the chat box. Who's ready to get started? Awesome. Excellent. We have so many students joining in. I'm very excited. One thing that I just want to really advocate and encourage for is over this 1 hour, I would just highly recommend you cut out any distractions. You're here to really optimize your performance. And I would love for you to have just 1 hour of focused questions with me so that you can retain the most amount of high yield material. So what we're going to do today is we're going to go into multiple choice questions. I'm going to go through some questions, and then I'm going to have you join in and answer some questions in the chat box. We'll kind of alternate back and forth. What we will do is we'll use the question to kind of go into the content review, and I'll do a little bit of a chalk talk style where I'll be explaining the concepts so that you can take notes while we go through each of the questions. One unique aspect of today's session is a USMLE take-home message. I am going to be categorizing specifically what organ system is the question from, what is the question type, what is the content that the question is testing you on. I'm going to give you a quick little mini paraphrase of how to capture the essentials, the pertinent positives, so to say, of the question. And then one thing that is super unique, and it will kind of go towards all of you who are avid Anki users, is I'm going to take a question and then just give you one extra step, one extra rep by asking you a quick active recall question that is going to correlate to the multiple choice question, which you will just do. So keeping on with the session, the first thing that I want to do is just lay down some fundamentals. And this is from my test taking strategies course. And for more information and details, feel free to check that out. What we're first going to be going through is the anatomy of an exam question. You know, I have gone through the question writer guide. It's about an 80-page document put out by the NBME of how to write high fidelity exam questions. And many exam questions have certain building blocks. And so this is Bob the Builder. And what we will go through right now is the building blocks of a USMLE question. So many USMLE questions are going to, actually all USMLE questions are going to have a STEM. And for USMLE step 1, usually the STEMs are going to be focused around what's the most likely diagnosis and what is the most likely mechanism. Subsequently, after the STEM, you will kind of go to the top portion of the vignette and you will integrate all of these other building blocks. The first is going to be the chief complaint. What is going to kind of expand on the chief complaint is the history of present illness, or HPI. The past medical history is also going to be important in your vignettes, along with medications. Remember, medications sometimes can correlate to the past medical histories. So for example, in the medications, if they put hydrochlorothiazide, you'll probably see in the past medical history a history of hypertension, for example. So always try to play that relationship. Social history, in particular, risk factors such as smoking or high-risk sexual activity, family history, especially when you're thinking about genetic questions. And then afterwards, you'll kind of pivot and go from the patient's perspective and then integrate the doctor's perspective. And the key here is to recognize that your vital signs, physical exam, labs, and imaging are more of the medical components that relate very closely to the HPI, past medical history, et cetera. For example, if somebody in the chief complaint comes in with a rash and they say that the rash is going to be red and hot, well, typically on the physical exam, they will say an erythematous confluent rash with fluctuance and warmth on palpation. So it's kind of the same thing, and try to think about a vignette in a patient perspective and then a provider perspective, because then you'll see what themes are being built. One of the other ways to kind of conceptualize what we're going to be doing today and how to get good on your UWorld and NBME questions is to think about these building blocks as kind of funneling down to a working diagnosis or a mechanism. So what the USMLE, especially in UWorld questions, what they like to do is they like to take a broad chief complaint, and then they will start giving you data points from history, physical exam, labs, etc., so that you narrow down to a working diagnosis or a working mechanism. And so start broad and then go narrow. Today, what we will be incorporating in this funnel model is learning a little bit about how questions are going to have pertinent positives and pertinent negatives. Pertinent positives help you develop a working diagnosis or a working mechanism that they are testing you on. whereas pertinent negatives lead you away. So for example, in an exam question, if they say that troponins are negative, typically they're not going to be going down the route of acute coronary syndrome or myocardial infarction. So typically pertinent negatives are going to have no, negative, and normal stated within the vignette sentences. And that helps you shift away. They're not testing this diagnosis. They're not testing this type of mechanism. So our goal as we go through these questions is to figure out what is going to be the most likely mechanism or the diagnosis behind these questions and vignettes. All right, so with that overview, we're going to go ahead and get started. If you are in the Zoom chat room, what we are going to do today is I'm going to change the Zoom chat feature so that you can put your answers only to me. And what I will do is read through the question, and then subsequently I will break down the question. And once you read through the question with me, try to figure out what the answer is and put it into the chat box, or if on YouTube, put it into the YouTube live stream. All right. STEM. Which of the following portions of the nephron is most likely to be affected? A 60-year-old male with dyslipidemia presents after a myocardial infarction. He is admitted to the intensive care unit and is noted to have decreased urine output on hospital day 3. His labs are as follows: BUN 19 on day 1 with the creatinine of 0.9. Today, it is going to be 30 and 2.8. The urine microscopy reveals heme granular casts. Repeat echo shows an ejection fraction of 20%. Which of the following portions of the nephron is most likely affected? I'm going to give you 30 seconds to think about this question. Go ahead. Excellent. So let's go through this question. This patient has many atherosclerotic risk factors and is going to have a very low EF and signs of intrarenal kidney injury, specifically the diagnosis of acute tubular necrosis. Remember that when you get a renal set of labs, you want to look at the BUN to creatinine ratio. And if the BUN to creatinine ratio is like 10 to 15, you're going to be thinking about intrarenal injury. And in this case, it's due to ineffective glomerular perfusion because of the low cardiac output state. So what area of the nephron is very susceptible to ischemic injury? The answer is going to be the proximal convoluted tubule, because that is going to be the most metabolically active. Another acceptable answer choice is actually going to be the medulla of the kidney, but that is more of the macro anatomy if they go for that. All right, so this is going to be a renal question that was testing your interpretation or test-taking strategy of labs. The diagnosis is acute tubular necrosis. Remember that if you wanted to capture this vignette, you would say, hey, the patient has an MI that caused a low ejection fraction. He had decreased urine output because the heart wasn't able to perfuse the kidney. And then he had ischemic injury, creating muddy brown cast, which is a hallmark of acute tubular necrosis. So what would be the likely BUN to creatinine ratio? That is going to be 10 to 15 to 1. So i.e., it is going to be a relatively normal BUN to creatinine ratio. All right. Next question. I'm going to go ahead and go through this one. Which of the following additional lab changes would be noted? A 40-year-old female presents with itching in the vaginal region. She was recently diagnosed with a UTI 1 week ago and was prescribed a course of nitrofurantoin. She is sexually active and uses barrier contraception. Her vital signs are going to be stable. The perineum exam is notable for thick plaques of white discharge adherent to the vaginal mucosa. Which of the following additional changes would be noted on laboratory studies? A, clue cells, B, motile pear-shaped organisms, C, normal vaginal pH, or D, cervical inflammation? Awesome. Really great set of answers here. Let's go through the quick breakdown. As you can see in this question, the patient has signs of vaginitis, i.e. itching and inflammation of the vaginal region. She had this trigger. That is very important to note in the USMLE questions, is anytime you have a chief complaint, look for a trigger. In this case, the antibiotics caused a decrease in the normal vaginal mucosa. Subsequently, you note the characteristic of the discharge, and that is going to be a white discharge, indicative of Candida. Candida is going to be one of the causes of vaginitis that actually gives you a normal vaginal pH. Remember that when you're thinking about Gardnerella or Trichomonas, you're going to have an elevated vaginal pH. Answer choice A is going to represent clue cells, which is bacterial vaginosis. Answer choice B and D are going to be pointing more towards trichomoniasis. So this was a question related to repro, microbiology, testing you on Candida vaginitis. The paraphrase of the vignette is recent antibiotic use, which is a trigger, and then this thick cottage cheese discharge. They may say on scrapings or on microscopic analysis, they may say hyphae indicating Candida. And one of the treatment options we use for Candida is fluconazole. So what do you think is the mechanism of action of fluconazole? Think to yourself. And that is going to be 14-alpha demethylase inhibition. Remember that the 14-alpha demethylase inhibition inhibits ergosterol, and ergosterol is kind of like cholesterol because it is going to normally be incorporated in the fungal cell membrane. However, if you inhibit 14-alpha demethylase, you don't get good ergosterol, and you then have fungal cell membrane damage, and that's how you are going to fight against Candida. Next question. Which of the following pathophysiologic mechanisms is likely present in the experimental group? A research study is studying, a group of smokers and changes in lung function. A curve is plotted compared to normal. Which of the following pathophysiologic mechanisms is likely present in the experimental group? A, compression atelectasis, B, VQ mismatch, C, increased neutrophil elastase, D, intercostal neuromuscular fatigue, or E, pulmonary fibrosis. Give you about 30 seconds. Awesome. So one thing that I want to go through is how I approach experimental questions. So experimental questions are really rampant on the USMLE. With experimental questions, this is also in my test taking strategies course, I like to go through a few series of steps. Number one, I like to isolate what outcome are the USMLE test writers going for in the experiment. The second thing that I like to do is I like to isolate the intervention group and compare that to the control group. And then finally, one of the unique test-taking principles that I would encourage you to keep in mind is you want to figure out what part of first aid are they testing as they are describing the experiment. So in this situation, they are testing you on respiratory pathology, specifically the difference between obstructive versus restrictive lung disease. So that helps you conceptualize the question a little bit. As you can see on this curve, you notice that this is going to be a flow volume loop. Inspiration in normal is going to be here on the bottom, and the patient is going to be up here. But characteristically, in the expiratory limb, you see a flow limitation, i.e., the patient can't get the air out. So is this going to be more restrictive or obstructive? Well, with the scooping and the inability to get the air out, it is going to be an obstructive lung disease. And out of all of these, the most obstructive lung disease and the one related to smoking is going to be emphysema. And remember that emphysema is due to increased neutrophil elastase, and that is going to break down the alveolar capillary membrane, sometimes even causing cystic dilations that then cause air trapping. Other things for us to note here is that intercostal neuromuscular fatigue, this is going to be the answer choice related to myasthenia gravis or Guillain-Barré syndrome. Remember that intercostal neuromuscular fatigue is going to be a restrictive lung disease along with pulmonary fibrosis. With pulmonary fibrosis, you're going to have a decreased DLCO, which is the diffusing capacity of the lung, whereas in something like emphysema, you may even have increased DLCO because that alveolar capillary membrane is going to be so thin and broken down. So this is going to be a respiratory question testing you both on graph interpretation and experimental. It was specifically going for obstructive lung disease. And the key here was smoking and the scooped waveform on the flow volume loop, particularly on the expiratory limb. So what happens to the FEV1 to FVC ratio in obstructive lung disease? Why don't you think to yourself, what happens to the FEV1 to FVC ratio? And if you said decreases, you are absolutely correct. And the hallmark of obstructive lung disease is a low FEV1. Really important for you to note. Before I go on, are you all learning something? Go ahead and type in yes into the chat box. Everybody good, staying active and engaged? Excellent. You all are doing great. I know that there's a good pace to this session, so really appreciate your feedback as well. All right, let's go through our next question. Which of the following is going to be the most likely diagnosis? A 30-year-old male is found at a local restaurant very agitated. He states he came to the restaurant to tell everyone he is God's second coming. For the past week, he was thinking about this all night and was able to document his thoughts in a notebook. Mental status exam shows increased fidgeting. Physical exam is going to be normal. Drug screen is going to be negative. Which of the following is the most likely diagnosis? A, bipolar 1, B, bipolar 2, C, schizophrenia, D, schizoaffective, E, major depressive disorder with psychotic features. All right. So in this situation, you notice that the patient is going to have a very elated mood. So they are going to be very agitated. They may even have some element of psychosis. But you notice here that for the past week, the patient is going to have a decreased need for sleep, some pressured speech, and they are going to overall have on edge type of manic episode. The key in this question are these pertinent negatives, which the physical exam being normal, indicating bipolar is more of a psychiatric condition, and the drug screen being negative. Because remember, things such as cocaine can mimic this presentation because cocaine is like an upper. The other important thing that I would note in exam questions, particularly for psych, is to pay attention to time period. Because in this situation, the patient meets the criteria for bipolar 1 based on the manic symptoms as well as the time period. Whereas, for example, schizophrenia would be 6 months, or with schizoaffective, the patient would need to have 2 weeks of primarily only schizophrenia symptoms without the affect symptoms. So what we have to go through in this situation is the mnemonic of dig fast, which is distractibility, irritability or impulsivity, grandiosity, fast speech. A is going to be a attention problem. S is going to be a decreased need for sleep. T is going to be talkativeness. You must have greater than 3 of these symptoms for about a week to be considered a manic episode. And remember that you're going to clinch the diagnosis of bipolar 1, especially if the patient is going to have some psychotic symptoms, i.e. delusions or hallucinations during the manic episode. Now, what are going to be the pharmacological mood stabilizers in bipolar 1 disorder? Think to yourself. Awesome. Many people are saying lithium. And if you said lithium, valproate, lamotrigine, you're absolutely correct. Remember that valproate and lamotrigine, they are also going to be anti-seizure medications. Typically, when you think about anti-seizure medications, the answer usually is sodium channel blockade. And remember that valproic acid can be actually hepatotoxic, and it can be a teratogen because it is going to inhibit folate metabolism. Okay. Very good. Let's keep going. Which of the following vaccine characteristics would confirm this hypothesis? A research trial is developing a new vaccine which is effective against a novel virus. The researchers would like for the vaccine to be a single dose series with increased memory response. Which of the following vaccine characteristics would confirm this hypothesis? A, a pure B cell response, B, polysaccharide, C, polysaccharide protein conjugate, D, lack of toxoid protein, or E, short duration of immunity. What do you all think is the best answer here? Awesome. If you said polysaccharide protein conjugate, you're absolutely correct. Remember, for the memory response to ensue, just an immunology tie-in, you need T cells. And how do you get T cells? Well, MHC presentation. And you need a protein component to present on either MHC1 or MHC2. So this is an immunology-based question. I framed it in more of an experimental mindset. It was testing you on vaccines. Remember that vaccine and memory response, they're going for a T cell mediated response. And as a step beyond question, let's go through this. MHC1 processes what type of antigens? Are they more intracellular antigens or extracellular antigens? What do you think is the best answer? MHC1, what type of antigens do they process more? Excellent. If you are saying intracellular, you are absolutely correct. Remember that MHC1 is related to CD8 positive T cells. The other thing for us to note is that the intracellular processing requires a very important protein known as TAP. The TAP is going to be cleaved in the endoplasmic reticulum, and then the protein antigen can then get loaded on to the MHC1 receptor and then get presented to the CD8 positive T cell, which then undergoes an extrinsic apoptosis pathway that involves caspases and essentially having perforins and granzymes come into the cell that is affected and create apoptosis. What I just did there was I went immunology, went into a little bit of cellular mechanisms, and then I went into GenPath, specifically talking about apoptosis. And we're going to be going through that in subsequent questions. But very important for you to know MHC1, CD8, and T cells needing to be present for a memory response. All right, let's go through this question. Which of the following abdominal CT labels best corresponds to the area of pathology? An 18-year-old male presents with abdominal pain. He has a long-standing history of cystic fibrosis. He states that since attending college, he has noticed voluminous, foul-smelling stools. Vital signs are going to be normal. Physical exam shows mild epigastric tenderness. Ova and parasite exam is going to be negative. Increased lipid is going to be noted in 72-hour fecal fat collection. Which of the following abdominal CT labels best correspond to the area of pathology? Go ahead and think to yourself, what do you think is the best answer? Awesome. Very good. So this patient has a history of cystic fibrosis. Remember that patients with cystic fibrosis are going to have thick secretions. Particularly, they'll have thick secretions in the pancreas, the respiratory system, and even throughout the GI tract. So in this situation, the patient is noted to have exocrine pancreatic insufficiency. And how do you recognize that? Well, they have signs of malabsorption. So foul-smelling stools, increased fecal fat, and this all relates to the pancreas. So in this abdominal CT, remember that this is the right side of the patient. This is the left side of the patient. This is going to be the liver and the gallbladder. This is going to be on the right side. That is going to be the inferior vena cava. Remember, inferior vena cava drains into the right atrium. This is going to be the left kidney. And here is going to be your answer choice E, which is going to be the pancreas. One of the key things that I put here are that ova and parasite studies are going to be negative, indicating that this is not going to be a microbiological agent that is going to cause fat malabsorption. The classic one that you will get tested on is Giardia. Giardia can give you the increased fat and foul-smelling stools. So this was a gastrointestinal question testing you on imaging, specifically abdominal CT imaging. We are going to interrelate the exocrine pancreatic insufficiency that patients with cystic fibrosis can get. So watch for the foul-smelling stools plus cystic fibrosis. Remember that if they want to test you on the endocrine manifestations of cystic fibrosis, you're going to be thinking of hyperglycemia because the pancreas is going to have thick secretions. That's going to cause a destruction of the islet cells, the beta islet cells, and then subsequently you're going to have less insulin, and that's why you're going to have hyperglycemia. So here's a little bit of an anatomy question. The tail of the pancreas is located within which GI ligament? The tail of the pancreas. And that is going to be in the splenorenal ligament. And so remember, the tail of the pancreas is also going to be, if you think about the pancreas, the tail is more towards the left side of the body. So if you think about the pancreas being here, here's the tail, it is going to be right near the spleen, the area number 3, as the splenorenal ligament goes a little bit more retroperitoneal. All right, next question. Which of the following pharmacological mechanisms of action may relieve the patient's symptoms? A 58-year-old male presents with hesitancy while urinating. The patient has tried to reduce stress levels, however, continues to have difficulty initiating urinary stream. He is on hydrochlorothiazide for hypertension and intermittent phenylephrine nasal spray for allergic rhinitis. The patient undergoes renal ultrasound, which shows mild bilateral hydronephrosis. Which of the following pharmacological mechanisms of action may relieve the patient's symptoms? A, 5-alpha reductase inhibition, B, aromatase inhibition, C, cholinomimetic inhibition, or D, alpha-1 agonism. What do you think? Awesome. In this situation, the patient is going to have what? Well, the patient is going to have urethral outlet obstruction secondary to benign prostatic hyperplasia. Benign prostatic hyperplasia, you're going to get hesitancy while urinating, difficulty initiating a stream. The patient having bilateral hydronephrosis indicates that the prostate is compressing the urethra, and you are going to get a lot of back pressure that is going to cause the renal pelvis to swell, i.e. cause hydronephrosis. So remember that the prostate is going to grow due to what hormone? It is going to be dihydrotestosterone, i.e. more dihydrotestosterone, the more the prostate grows. So dihydrotestosterone comes from normal testosterone, and the enzyme is very high yield, 5-alpha reductase. So if you use a medication called finasteride to inhibit 5-alpha reductase, you have less DHT and less benign prostatic hyperplasia, and you open up the prostatic urethra. So the best answer here is going to be A. Remember that phenylephrine is actually going to be an alpha-1 agonist. And what does alpha-1 agonist, what do alpha-1 agonists do to the external urethral sphincter? It's going to contract it. So alpha-1 agonism would not be the correct answer. It's actually alpha-1 antagonism. So the OSIN drugs, tamoxifen, prazosin, all of those are going to be alpha-1 antagonists and thus open up the prostatic urethra, helping the patient's symptoms. So this was a reproductive pharmacology question going through the USMLE content domain of BPH. Watch for urinary hesitancy and bilateral hydronephrosis, indicating a lower urinary tract obstruction or a bladder outlet obstruction. And if we took this question one step beyond, let's go through this active recall question. What is the likely gross pathology change which would be noted in the bladder due to long-standing BPH? And so if you have compression of the prostatic urethra because your prostate is so large, the bladder is going to undergo detrusor muscle hypertrophy because the bladder has to now contract against an obstruction. And over time, that is going to be a cellular stress that causes increased muscle growth and increased smooth muscle cells. So detrusor hypertrophy would be the gross pathology finding. All right, next question. Which of the following is the most appropriate statement by the physician at this time? A female newborn is noted to have intrauterine demise during the late second trimester of pregnancy. The ultrasound notes increased fluid surrounding the heart, extremities, as well as fetal ascites. Which of the following is the most appropriate statement by the physician at this time? A, I'm sorry, but we need to talk. B, you lost your pregnancy. Do you have family members around? C, I have some unexpected news. Would it be okay to share it with you now? Or D, I have some unexpected news. Let's call your husband so I can tell you both together. What do you think would be the best answer here? Awesome. So in my pass-fail course, I have a whole section on ethics, physician communication, and professionalism. In this situation, this is going to be a very sad event and big news. So you definitely want to set the stage. And how you do that is you want to invite the patient to see whether or not they're ready or whether they want to have the bad news at that particular time. So setting the stage is really key. So this was an ethics and communication question on delivering bad news. In this situation, they were going for fetal hydrops. So as a step beyond question, let's integrate. What is the structural morphology of the virus which is associated with hydrops fatalis? And if you don't know the structural morphology, just tell me what virus is going to cause hydrops fatalis. Awesome. If you said parvovirus B19, you're absolutely correct. And remember, parvovirus B19 is going to be a single-stranded linear DNA virus. All right, let's go through this arrow question. Which of the following changes in hemodynamics are expected during her sprint? A 26-year-old female athlete undergoes exercise testing. Physiologic parameters are ascertained while she sprints and reaches 85% of her maximum heart rate. Which of the following changes in hemodynamics are expected during her sprint? So you have pulse pressure, diastolic blood pressure, and systolic blood pressure. What do you think would be the best answer here? I'll give you about 30 seconds. So in this situation, it's really important for you to understand how to go through arrow questions. And so here's my test taking strategy on arrow questions. So for arrow questions, I like to, number one, make sure I predict the answer. I usually like to predict answers for all USMLE questions, but especially for arrow questions. So I'm going to predict the answer, and I'm going to go with the low hanging fruit, i.e., what parameter do I know is going to be changed in this question on exercise? And then from that low hanging fruit, I'm going to branch out to the other variables. So going back to this question, we note that they are testing me on exercise. And I know exercise is kind of like a fight or flight mechanism. So my systolic blood pressure is actually going to be high. And if my systolic blood pressure is going to be high, my pulse pressure is probably going to be high as well. So remember that pulse pressure is going to be the change, i.e., the difference between systolic blood pressure minus diastolic blood pressure. Now, your diastolic blood pressure is going to be unchanged or even slightly decreased. And this is an important concept because remember that during this fight or flight mechanism, you are going to have alpha-1 agonism that is going to cause you to have a slight increase in your diastolic blood pressure, but you're also going to have beta-2 agonism. And what is that going to do to the vascular smooth muscle cells? Well, it's going to relax them and cause vasodilation. So that vasodilation can actually decrease your diastolic blood pressure. So in exercise, your diastolic blood pressure is relatively unchanged or maybe slightly lower due to the beta-2 agonistic effect. So this is a cardiovascular arrow question testing you on the physiologic changes in exercise. What cardiovascular murmur increases pulse pressure? What do you think would be the cardiovascular murmur that increases pulse pressure? And if you said aortic regurgitation, you're absolutely correct. Remember that regurgitation causes that increase in preload, the head bobbing, the water hammer pulse, and the increase in pulse pressure. This is a beautiful diagram that goes through the physiologic changes in exercise. Remember that there are central and local controls. The central control is what we just talked about related to the increase in sympathetic outflow, the fight or flight. Remember that that causes you to have increase in heart rate, increase in contractility, and thus increase in cardiac output. So your chronotropy and your ionotropy are going to increase thanks to your catecholamines, epinephrine and norepinephrine. You're also going to get constriction of your splanchnic and renal arterioles. So that is going to mean that you're going to divert blood away from the gut and into the muscles where you're going to need to bring blood because of the high metabolic activity during exercise. And you're also going to have constriction of veins, and that's going to increase your venous return. So when you increase your venous return, you're going to have increase in preload. You're going to have increase in preload coupled with an increase in contractility. All of this is going to give you that increase in pulse pressure. And remember that the whole point of exercise is get blood flow away from your gut and into the skeletal muscle. Next question. Which of the following additional findings would be expected in this patient? A 77-year-old male presents with acute onset abdominal pain. He states that the abdominal pain is worse in the right flank region. He has a history of arthritis controlled on NSAIDs. On vitals, he is afebrile, hypertensive, and tachycardic. Physical exam notes right costovertebral angle tenderness and diffuse abdominal tenderness. Urine analysis is notable for microscopic hematuria. Which of the following additional findings would be expected in this patient? A urine culture that's positive for E. coli. B, ultrasound notable for benign prostatic hyperplasia. C, an increased BUN. Or D, renal papillary necrosis. What do you think would be the best answer here? Awesome. Some very good answers here. Let's go through the breakdown. So with this patient who comes in with abdominal pain, specifically flank pain, and microscopic hematuria, you are primarily going to be thinking of a kidney stone. The other important component to note here is this pertinent negative that I put afebrile with right CVA tenderness. This rules out pyelonephritis, and that's an important differential to keep in mind with patients who are going to come in with CVA tenderness on your exam. One unique component to note in this situation is that a kidney stone is going to be an example or a cause of post-renal injury. So if you are going to have the collecting duct right here, and there's a distal obstruction, all of that filtered load is going to go up and go backwards in the nephron, essentially. And you are particularly going to reabsorb more BUN and water. And that's the hallmark of post-renal injury, is actually an increase in BUN initially, followed by then intrarenal injury if the obstruction is going to be there for a while. Remember that renal papillary necrosis is going to be due to NSAIDs, sickle cell, as well as diabetes. However, renal papillary necrosis is not a cause of microscopic hematuria. It's more macroscopic hematuria. So in your questions, they will say that the patient is passing clots or passing tissue. So in this situation, I'm testing you on renal stones. And in particular, please note that unilateral flank pain plus microscopic hematuria. The step beyond question: where are likely anatomic regions where kidney stones can be dislodged? And there are three high-yield areas. Number one is going to be the UPJ, so the ureteropelviceal junction right at the kidney. Number two is the pelvic brim right near the iliac vessels. And number three, the ureterovesicular junction, and that's going to be right near the bladder. So know these three anatomic landmarks because that's where kidney stones get dislodged. And as a result, that is what's going to cause you to have the flank pain. All right, guys, we're going to keep going, but I want to pause here. Let's go ahead. Everybody take a deep breath. We're going through these questions pretty nicely. You guys doing okay? Go ahead and type in yes into the chat box. Everybody doing good? All right, great. And I appreciate your focus and attention. These are some high yield questions, high yield concepts. So let's go ahead and keep pushing on and getting some gains here. All right. So which of the following pathophysiologic mechanisms would support the ultrasound findings. A 40-year-old female presents with right upper quadrant pain. She has a history of hereditary spherocytosis diagnosed in infancy. She undergoes laparoscopic cholecystectomy. The stones in her gallbladder are noted to have decreased cholesterol and increased amounts of heme pigments. Which of the following pathophysiologic mechanisms would support the ultrasound findings? A, biliary tract infections. B, increased indirect bilirubin. C, increased direct bilirubin. Or D, increased enterohepatic cycling of bilirubin. What do you think would be the best answer here? Excellent. You all are doing absolutely wonderful in the chat box. If you said B, you're absolutely correct. So what's the key in this test question? This patient has a history of chronic hemolysis and now has gallstones. Remember, gallstones, right upper quadrant pain. Hereditary spherocytosis is going to be an example of hemolysis, or a cause, especially of normocytic anemia. And so whenever you have hemolysis, you are going to have an increase in indirect bilirubin, because when the red blood cell is going to break, it is going to release heme plus globin. And the heme is going to then get processed into bilirubin. And it is those bilirubin byproducts that can actually accumulate in the gallbladder, causing pigment stones. This increase in enterohepatic cycling of bilirubin is a wrong answer. And the reason why is you see this primarily in Crohn's disease, as well as in breastfeeding jaundice. And remember that biliary tract infections would be if the patient, for example, was an immigrant, they had a infection with either ascending cholangitis or some sort of liver fluke. So this is a GI question testing you on pigment stones. Watch for chronic hemolysis and right upper quadrant pain. So just taking this one step beyond, what lab value confirms a diagnosis of intravascular hemolysis? Think to yourself, what would be a key diagnosis factor for intravascular hemolysis? And that is going to be a low haptoglobin. Remember that the free heme in the intravascular space is bound up by haptoglobin. So if your haptoglobin is low, that means that you have intravascular hemolysis. All right, next question. Which of the following genetic mechanisms may explain the gross pathology findings? A 33-year-old male undergoes autopsy after sudden cardiac death. The autopsy results of the patient's coronary vessels are noted in the image. Which of the following genetic mechanisms may explain the gross pathology findings? A, autosomal dominant mutation of LDL receptor gene. B, genetic mutation leading to increased clearance of IDL. C, decreased lipoprotein lipase gene activity. Or D, a genetic mutation leading to decreased microsomal transfer protein. What do you think is the best answer here? Awesome. So real quick, I wanted to go through the test taking strategy for image-based question. So anytime I see an image on the USMLE, I like to go through 3 steps. Number 1, I like to categorize whether or not the image is going to be gross, microscopic, or radiographic. And in our prior questions, we had a lot of radiographic findings, but this is a gross pathology image. And the second test taking step that I like to take with image-based questions is of what is it? Of the coronary. And then what you'll do is look for things that you know, look for things that you don't know, And when in doubt, look for asymmetry in the image. So here is going to be a coronary vessel that is going to have thrombus and lipid streaks on gross pathology. And so likely this patient suffered, given the age as well, familial hypercholesterolemia. And this is going to be an autosomal dominant mutation of the LDL receptor gene. Remember that when you're thinking about answer choice D, you are going to be thinking of the diagnosis of A beta lipoproteinemia, in which you are not going to have good conjugation with ApoB48 and ApoB100. And these are important for VLDL as well as for chylomicrons. So this is going to be an image-based question testing you on premature atherosclerosis. Remember that this patient had a coronary, acute coronary event due to almost near occlusion of the vessel, both of atherosclerotic plaque as well as thrombi. So let's go through this step beyond question. A patient is found to have elevated homocysteine levels, leading to increased risk for cerebrovascular disease. What is the likely enzyme defect that is causing the elevated homocysteine level? Think to yourself. Excellent. And if you said cystabetadione synthetase deficiency or methylene tetrahydrofolate defect, you're absolutely correct. Remember that CBS is going to be the enzyme that is going to be deficient when a patient has homocystinuria. Elevated homocysteine can actually cause you to become hypercoagulable and can even accelerate atherosclerosis. Remember that this enzyme, CBS, cystabetadione synthetase, is going to need B6. And in your exam questions, watch for a marfanoid habitus in patients who have homocystinuria. And typically they have lens ectopia in the downward medial direction. All right, next question. Which of the following genetic translocations may be implicated in this disorder? A 65-year-old female presents with painless lymphadenopathy of the cervical region. Biopsy is performed noting increased expansion of lymph node follicles. Genetic evaluation notes translocation of heavy chain immunoglobulin to a key mediator in the intrinsic apoptotic pathway. Which of the following genetic translocations may be implicated in this disorder? A, 814, B, 1418, C, 1114, or D, 1118? What do you think is the best answer here? So in this situation, you are going to be transitioning or channeling your mind into non-Hodgkin's lymphoma. And this is primarily going to be a follicular lymphoma. And remember that follicular lymphoma is going to have the what translocation? The 1418 translocation. So I like to say follicular 14, follicular 14. And this is where you get the overexpression of BCL2. And BCL2 is a key mediator in the intrinsic apoptotic pathway. Too much BCL2, guess what? Decreased cell death, i.e. cells don't die. And if cells don't die, you are going to get cancer. 814, remember that's Burkitt's, and 1114, that is going to be mantle cell leukemia. So this is a hemonc genetics question that is going to test you on follicular lymphoma. Remember that this is a lymph node with Ig and BCL2 translocation. If you shift a little bit from BCL2 and you think about the other factors, which are the pro-apoptotic factors, BAX and BAC, think about this question. Increase BAX-BAC ratio in the intrinsic pathway of apoptosis causes release of which caspase activator? What do you think is the best answer here? So increased back causes release of cytochrome C, and that then downstream is going to activate caspases and lead to apoptosis. This is GenPath chapters 1 through 3 of Pathoma. Next question. Which of the following changes would be noted 3 to 5 days following this insult? A 60-year-old male presents with a focal neurological deficit when waking up. He has a history of difficulty with speech and swallowing. His vital signs are stable. Physical exam is notable for left-sided sensory and motor abnormalities in the lower extremities. Which of the following changes would be noted 3 to 5 days following this insult? What do you think is the best answer here? So anytime I see a focal neurological deficit in a USMLE question, I think about a stroke. And the way I approach it is I say, is it a hemorrhagic or is it going to be an ischemic stroke? In this patient, potentially you are going to have a ischemic stroke. And note that this patient is going to have both sensory and motor abnormalities. So you're going to channel your mind and thinking about large vessels like middle cerebral artery, anterior cerebral artery. Remember that about a week out, the neutrophils are going to go away and you are going to have macrophages come in. And the macrophages are going to clean up the actual increased myelin breakdown products. Macrophages in the central nervous system are known as microglia. So this is a neurology pathophysiology question testing you on ischemic stroke. Always think about a stroke when you see a focal neurological deficit on your USMLE exam questions. And given this patient's left-sided sensory and motor abnormalities, primarily in the lower extremity, what is the likely artery affected? And this tests you on your knowledge on the homunculus. So if you have a left-sided stroke, likely you're thinking about the right side of the brain. And so with this patient having more lower extremity, you're going to be thinking more of the right anterior cerebral artery. Again, contralateral, and then think about the homunculus. Your trunk and lower extremities are going to be here in the ACA, anterior cerebral artery distribution. Occlusion of which of the following coronary arteries best explains the troponin elevation? So a 58-year-old female presents with acute onset abdominal pain and shortness of breath. She has a history of type 2 diabetes and angina. Vital signs are notable for bradycardia. She undergoes full evaluation with EKG revealing ST segment elevations in leads 2, 3, and AVF. Troponins are elevated. Occlusion of which of the following coronary artery best explains the troponin elevation? A, left circumflex. B, left anterior descending. C, posterior descending branch of the right coronary artery. Or D, right marginal branch of the coronary artery. What do you think is the best answer here? Excellent. Well, if you're thinking about an inferior wall MI, you're absolutely correct. Please note that inferior wall MIs on the USMLE are going to present with ST segment elevations in leads 2, 3, and AVF. And what is the inferior wall? Well, it is the portion of the heart that is closest to the diaphragm, and it is going to be right at the interventricular septum. So you can kind of think of it like right around here. What is important for us to note is many patients are going to be right coronary artery dominant. So you know that the best answer has to be either C or D. And in this patient, the patient likely has a right coronary artery occlusion. And that right coronary artery occlusion is causing the inferior wall MI. And because of that transmural infarction, you're going to have cell injury and death that ensues. And that's why the troponins are elevated. One thing that I put in this question that is really unique and is notable is that in inferior wall MIs due to right coronary artery occlusion, you may get bradycardia. And why is that? Because the right coronary artery has a specific branch called the nodal artery, and it is that nodal artery that can then infarct the SA node, leading to the AV node picking up, and i.e. if the SA node is going to be infarcted and the AV node picks up, well, you already know that the intrinsic depolarization rate of the AV node is much slower, hence you are going to get bradycardia. Another unique component to this test question is to watch out for atypical presentations of myocardial infarction, especially in females. So this was an anatomy question testing you on inferior wall MI. Watch for 2, 3, and AVF. And let's go ahead and go through the step beyond arrhythmia question. Fixed PR segments with decreased conduction of QRS complexes describes which type of arrhythmia. So fixed PR segments and then a drop of the QRS. That's going to be second degree heart block, Mobitz type 2. So in Mobitz type 2, remember your PR segments are going to be fixed before a drop. Next question. Which of the following is most likely responsible for these findings? A 33-year-old male presents with increased thirst. He has a history of newly diagnosed hypertension and was started on a medication with lifestyle modifications. He is noted to have the following lab studies. As you can see here, the calcium is going to be high and the PTH is going to be low. Which of the following is most likely responsible for these findings? A, familial hypocalciuric hypercalcemia, B, embryologic defect in the third pharyngeal pouch, C, loop diuretic effect, D, primary hyperparathyroidism, E, primary hypoparathyroidism, or F, thiazide diuretic effect. What do you think is the best answer here? Awesome. If you're saying F, you are absolutely correct. So this is going to be a classic vignette for thiazide diuretic side effect. First off, what we note is that symptoms of hypercalcemia are going to be stones, bones, groans, psychic overtones, but these patients can also get nephrogenic DI because the calcium is going to plug up their aquaporins. So anytime I see increased thirst, i.e. polyuria and polydipsia, I say, okay, this patient has diabetes because polyuria, polydipsia, you got to think about diabetes. Now, diabetes could be due to diabetes insipidus or diabetes mellitus. But in this test question, I said that the glucose is normal. So you're going to be thinking primarily of diabetes insipidus. And you note that nephrogenic diabetes insipidus could be due to hypercalcemia. Well, when you have high calcium, you are going to feed back on your PTH to go down. And so that's why this is not going to be primary hyperparathyroidism because your PTH levels are actually low, not high. The other important contrasting point is that loop diuretics don't cause hypercalcemia. I say loop diuretics lose calcium, i.e. loop diuretics cause hypocalcemia. And please note that the embryologic defect in the third pharyngeal pouch is going to be a 22q11 deletion, i.e. that is going to be DeGeorge syndrome. And in that situation, you actually get primary hypoparathyroidism because the third and fourth pharyngeal pouch gives you the superior and inferior parathyroids. So in this situation, we were going for the side effects for hydrochlorothiazide. Watch for hypercalcemia, stones, bones, groans, psychic overtones, and the potential for nephrogenic diabetes insipidus. Hypercalcemia, low PTH, that's a normal physiologic feedback mechanism. What is the nephron transporter inhibited by hydrochlorothiazide? So that's going to be in the distal convoluted tubule and the sodium chloride or SIM transporter. Very good. All right, we're almost through this session. Stick with me. I know we're going a little bit over time, but I just want to make sure that we have a comprehensive review. So I really appreciate everybody's attention. We're going to be going into now this next question. Which of the following drugs is most likely drug X in the experiment? An intravenous injection of drug X was given to a laboratory animal before and after the administration of atropine. The heart rate was recorded. So on the on the y-axis, you will have heart rate. Which of the following drugs is most likely drug X in this experiment? I'm going to give you about 45 seconds because this is a little bit more of a challenging question. All right, let's go through this question. This question is going to be testing your strategy for graphs. So for graphs, I always like to look at the X and Y axes, and then I like to establish trends. So as you can see, when drug X is going to be administered, you are going to have a decrease in heart rate. Subsequently, when you are going to give atropine, which is going to be an anti-muscarinic, you are going to block the acetylcholine effect on the heart. And after you give drug X, you're actually going to get an increase in heart rate. So in this situation, when you are talking about an acetylcholine effect, it could either be a cholinomimetic, which none of the answer choices are cholinomimetics, or it could be an adrenergic agent that is going to be causing a reflex bradycardia due to the baroreceptor reflex. So for example, norepinephrine is going to cause alpha-1 agonism. It's going to vasoconstrict. Increased stretch is going to be noted at your carotid baroreceptors, and thus you're going to have a reflexive bradycardia. The reflexive bradycardia is going to be due to the vagus nerve and ACH hitting the SA node. Well, if you give atropine, you are going to block the reflexive bradycardia. And when you have norepinephrine, rather than reflexive bradycardia, you're now going to just have tachycardia. Why? Because atropine is blocking your reflexive bradycardia. So the best answer here is going to be A, norepinephrine. This was a very challenging question, testing you on your interpretation of graphs, and your content specification is going to be on autonomic pharmacology. Remember the reflexive bradycardia that you can get when patients are going to be hypertensive. The key here is to also integrate Cushing's reflex. And this is going to be seen in patients who have increased intracranial pressure on your USMLE. So watch for a brain tumor, watch for you having ventriculomegaly, as well as watch for patients who have papilledema, and then vital sign changes of hypertension, bradycardia, and irregular respirations. So what cranial nerve mediates the afferent limb of the baroreceptor reflex, i.e. the input into the central nervous system? And that is going to be cranial nerve 9 and 10. So remember that cranial nerve 9 and 10 are going to really mediate the stretch effects at the level of the baroreceptor, i.e. the carotid sinus. So in this situation, norepinephrine caused increased amounts of stretch. Cranial nerve 9 gave the afferent limb, and then you had a vagal response before atropine inhibited that vagal response. Which of the following adrenergic agonists is most likely described in this experiment? A medical student studying autonomic pharmacology notes a medication which causes increased renal blood flow followed by an increase in cardiac output in a dose-dependent effect. So first, increased renal blood flow followed by increased cardiac output in a dose-dependent effect. Which of the following adrenergic agonists is most likely described in this experiment? What do you think is the best answer? A, dobutamine, B, dopamine, C, epinephrine, D, norepinephrine, or E, isoproterenol? So that increase in renal blood flow followed by an increase in cardiac output is basically testing your knowledge on dopamine and how dopamine first hits the D1 receptor, causing increase in glomerular perfusion. And then in a dose-dependent fashion, it is going to cause an increase in cardiac output because it starts tickling the beta 1 receptor. So this was an experimental question testing you on autonomic pharmacology. Remember that dopamine causes renal perfusion followed by, in a dose-dependent fashion, an increase in ionotropy. What G protein couple receptor does dopamine act upon in the kidney to increase glomerular perfusion? Is it going to be GS, GQ, GI? What do you all think is the best answer? What G protein couple receptor does dopamine act via? Excellent. And if you said GS, you are absolutely correct. Remember that dopamine D1 receptor, that's more in the kidney, D2 receptor, that's in the central nervous system. And that's going to be all of your questions related to schizophrenia and antipsychotics. Which of the following bacterial morphologies may be implicated in this patient's illness? You have a 19-year-old female presents with burning with urination. The patient has a history of sexual activity. Vital signs show fever and tachycardia. Physical exam notes mild suprapubic tenderness with no CVA tenderness. Laboratory results note an increase in urine WBCs, as well as leukocyte esterase and positive nitrites. Which of the following bacterial morphologies may be implicated in this patient's illness? Awesome. If you're thinking of E. coli, you are absolutely correct. It's one of the most common causes for a UTI. So in this situation, please note the following, that this is a UTI, and this patient has a UTI primarily because, again, you don't have any CVA tenderness. No CVA tenderness, likely they're not testing you on pyelonephritis. So that's a nice pertinent negative. The mild suprapubic tenderness is going to point to your bladder being irritated, i.e. cystitis or a UTI. Also note that whenever you see positive nitrites, it's going to be a gram-negative organism. So that's why something like Staph saprophyticus, which is going to be answer choice A, is not going to be the correct answer. So D, gram-negative rod, describes E. coli. So this was a micro question going for UTI. Watch for dysuria, suprapubic tenderness, leukocyte esterase and nitrite positivity that helps you conceptualize a UTI. And to take it a step beyond, what enzyme produces nitrites by taking nitrates and turning it into nitrites? This is found in gram-negative organisms, and it's called nitrate reductase. And so anytime I see nitrite positivity, I know I'm dealing with the gram-negative organism. All right, very good. Let's keep going. What is the likely mediator causing this patient's symptoms? A patient presents with a rash. She recently went to an outdoor fair and purchased jewelry at a local booth. She then had a family outing in the local national park where they spent the whole day hiking. She now presents with a linear rash that is across her shin region, and there are mild vesicles that are going to be noted. She has been afebrile. What is the likely mediator causing this patient's symptoms? NK cells, plasma cells, basophils, or T cells? What do you think is the best answer here? Awesome. If you're thinking about contact dermatitis, you're absolutely correct. The whole hiking and then the linear vesicular rash, that is going to be pointing to poison ivy. I even put, oh, she purchased jewelry, indicating that this could be a contact dermatitis. Sometimes patients can have like a nickel allergy. All in all, type 4 hypersensitivity. It's your delayed T cell mediated hypersensitivity. And so answer choice is going to be D. Whenever you see vesicles, I also think about herpes, but sometimes because herpes is a viral etiology, they would put, oh, the patient is febrile. So that was an important pertinent negative there. So this was a derm question that was testing you on an immunological mechanism, type 4 hypersensitivity. Watch for the linear streaking vesicular rash that is going to point towards poison ivy. Let's take this question a step beyond. What specific type of T cell mediates this response? And that's going to be your CD4 positive T cells. And the allergic component to these the allergic component in poison ivy is this urushiol, which is going to actually be the irritant. So type 4 hypersensitivity, it all involves an antigen that is going to cause activation of either CD4 or CD8. Typically, it's going to be a CD4 T helper cell. And then finally, you are going to have a T cell mediated immunity reaction. That's why they call it the delayed hypersensitivity effect. All right. What is the likely pathophysiologic basis behind this presentation? A patient presents after being found at summer camp with violent shaking of his upper and lower extremities. The patient is febrile and altered. CSF studies are notable for a negative gram stain and lymphocyte predominance. What is the likely pathophysiologic basis behind this presentation? What do you think is the best answer here? Answer choice is going to be B. So let's go through this question. Anytime I see fever plus altered mental status, I'm going to be thinking of the diagnosis of encephalitis. And this patient is going to have not a bacterial cause because of a negative gram stain, but actually a viral cause. And usually when you're thinking about the summer months, et cetera, you're going to be thinking of some sort of arthropod-borne transmission causing encephalitis. Remember that because it is inflammation of the parenchyma of the brain, you can actually have generalized tonic-clonic seizures as your presenting sign. So this was a very nice vignette that tested you on the concept of aseptic meningitis, i.e. it's not due to bacterial meningitis? And what are the organisms related to aseptic meningitis? There are going to be 3 of them that you should know. Enteroviruses are the general class, but particularly Coxsackie, Echo, and polioviruses. All right, everybody, we have just about 12 more questions left. If you guys are hanging with me, go ahead and type in yes into the chat box. I see some people who are participating galore, which is absolutely awesome. I'm going to stick around at the end and also answer any questions, but really appreciate everybody's attention as we go through these questions. Again, I want to really give you a solid review and do about a block of questions because that's an efficient way for us to go about it. Okay, so we are 12 questions away from the finish line. So let's go ahead and keep going. What is the likely diagnosis? A 55-year-old male presents with a concern for prostate cancer as he recently noted that his father passed away from prostate adenocarcinoma at the age of 77. The patient has been nonstop researching this illness and is constantly worried that he may be suffering from the same condition. The patient was evaluated in an emergency department 2 weeks ago and had normal labs and normal abdominal CT findings. What is the likely diagnosis? A, malingering, B, conversion, C, illness anxiety disorder, or D, somatic symptom disorder. What do you think is the best answer here? Excellent. So this patient has minimal to no symptoms and negative evaluations. So the best answer is illness anxiety disorder. Illness anxiety disorder, the illness script to kind of keep in mind is no symptoms and preoccupation with severe illness. So the step beyond question is, what would suggest somatic symptom disorder, which was the last answer choice? And that would be multiple somatic symptoms that can't necessarily be tied into one fitting script or one fitting diagnosis. So illness anxiety disorder, there's like no symptoms. Patient just is very fixated on having some sort of cancer, etc. This used to be called hypochondriasis before illness anxiety disorder. Which of the following pathophysiologic mechanisms would best explain this patient's symptoms? 1-week-old baby presents with yellowing skin, pale stools, and dark urine. Fractionated bilirubin shows an increased conjugated bilirubin. Which of the following pathophysiologic mechanisms would best explain this patient's symptoms? A, extrahepatic occlusion of bile ducts. B, increased enterohepatic circulation of bile salts. C, UDP glucuronyltransferase deficiency. Or D, autoimmune destruction of lobular bile ducts. All right, very good. So this is actually going to be the presentation of biliary atresia. So this means that your gallbladder tree is essentially underdeveloped and you have extrahepatic occlusion of bile ducts. Remember that if you're thinking of this being the liver, you have indirect bilirubin that comes in and direct bilirubin that is going to get conjugated in the liver and then subsequently get stored in the gallbladder tree. No gallbladder tree, the liver conjugates the indirect bilirubin, but then you have a high direct or conjugated bilirubin fraction. And so whenever you see hyperdirect bilirubinemia and acolic stools, you want to be thinking of the diagnosis of biliary atresia. So A is the correct answer, extrahepatic occlusion of bile ducts. This is a GI pathophysiology question testing you on biliary atresia. Remember that it is going to be primarily a conjugated hyperbilirubinemia. The baby is going to have jaundice as well. If you had a patient with ulcerative colitis with biliary tract disease, what is the autoantibody that may be positive in this situation? So this is a particularly important biliary tract disease associated with ulcerative colitis. And that is going to be primary sclerosing cholangitis. That is going to be P-ANCA positive. Remember that primary biliary cirrhosis, or PBC, is anti-mitochondrial positive, whereas PSC, primary sclerosing cholangitis, that's going to be P-ANCA positive. Things to note is the association with ulcerative colitis. They also say onion skin fibrosis in your exam questions and beading on ERCP, indicating the autoimmune destruction of the intra and extrahepatic bile ducts. What is the likely diagnosis? A 55-year-old male presents with a concern for prostate cancer. Oh, I apologize. This might be the same question. So it is the same keyed question. Let's go ahead and go on to this next question. I apologize for that. All right. So which of the following is most likely seen in this patient? A patient with congestive heart failure takes losartan. What do you think is the best answer here? If you take losartan, what do you think would happen? So this is a classic type of question that tests you on pharmacological mechanisms. In this situation, you have to note that angiotensin II receptor blocker is known as losartan. If you have an angiotensin II receptor blockade, your levels of angiotensin II go up, as well as upstream products. Think about a train that is going to essentially back up, or a traffic jam that backs up. And downstream, you are going to have decreased amounts of aldosterone. And subsequently, if you have decreased amounts of aldosterone, you're going to have an increased amounts of renin as well. So the best answer is going to be C, high renin, high angiotensin II, and low aldosterone. So this was an arrow question testing you on hypertension and pharmacology. If a patient had an increase in aldosterone, what acid-base abnormality would be possible? Think to yourself, high aldosterone, what acid-base abnormality would you have? So you would bring in more sodium and pee out more potassium and hydrogen ions. So you would have a metabolic alkalosis. You got it. Metabolic alkalosis in hyperaldosteronism. All right, let's go through this schematic. Which of the following would explain a change between drug A to drug C? Researchers are noting the following changes amongst multiple experimental medications. So you have A going down to C on a dose of the drug and effect of drug scale. A, increased efficacy. B, decreased potency. C, decreased efficacy. Or D, increased potency. Guys are doing great. Very nice. So in this situation, you see a decrease in the peak effect of the drug. And as a result, you are going to be thinking of decreased efficacy. Remember that if you had a change from a curve B to curve A, you would have a change in potency, because you note that A is going to be a very potent drug compared to B, because you are going to have a lower ED50. And ED50 is going to be the dose that causes 50% of the max effect. So low ED50 means that you have a high potency. In this situation, from curve A to curve C, you're decreasing the effect of the drug, i.e. the efficacy. So this was a graph-related question that was testing your knowledge on the difference between efficacy and potency. This is a general pharmacology principle question. And taking it one step beyond, let's go through this active recall question. A 5 milligram dose of chlorothalidone and a 25 milligram dose of hydrochlorothiazide have the same effect. What would be the difference in their ED50? i.e. chlorothalidone, would it have a higher ED50 or a lower ED50? What would chlorothalidone have? A higher or a lower ED50? So they both have the same effect, so their efficacy is the same, but chlorothalidone, you only need 5 milligrams. So you have a very highly potent diuretic, and thus the ED50 is going to be low. You don't need much to create 50% of the maximal effect. All right, guys, we are almost done. Let's go ahead and go through this question. What is the likely cause of the patient's findings? A 30-year-old female presents with severe itchiness after showering. The patient is a smoker. Physical exam is notable for splenomegaly and a reddish hue to the face. Labs are notable for increases in hemoglobin, RBC, platelets, and WBCs. What is the likely cause of the patient's findings? A, increased RBC lifespan. B, increased JAK tyrosine kinase activity. C, chronic hypoxia. D, type 1, or E, type 4 hypersensitivity. All right, very good. So the best answer here is going to be B, increased JAK tyrosine activity. This patient is going to have a very characteristic presentation, itchiness after showering, and increase in all cell lines. You're going to be worried about polycythemia vera, which is due to JAK mutations. Remember that the patient is going to have increased viscosity of the blood because there's just so much hyperproliferation, and that's why you get the reddish hue. The itchiness is going to be due to the amount of histamine. And also note that whenever you have chronic hypoxemia, say to obstructive sleep apnea, you are going to have elevations in EPO, but that only causes an increase in RBCs or hemoglobin or hematocrit, not your platelets and WBC. So all of those cell lines being up, you're worried about polycythemia vera. So question take home here is that the patient has, and I apologize, the patient is, this is going to be a heme question that is going to be testing you on pathophysiology and lab interpretation. The content specification is going to be polycythemia vera. Watch for itchiness after a shower and a ruddy complexion. And remember the step beyond question, which I will say is an increase a decrease in O2, i.e. hypoxemia, is going to cause an increase in EPO. Okay, very good. All right. A patient with chronic mitral stenosis leading to dysphagia has a structural change to which of the following structures? Please note, this is the left side of the patient. What do you think is the best answer here? Excellent. So if they have mitral stenosis, that is going to cause esophageal compression, what you're thinking of then is the left atrium. So these are the pumping chambers of the heart because they're more muscular. And so this is going to be the left atrium right here. Answer choice B. This is the left ventricle. This is the right atrium. This is the right ventricle. So this was testing you on mitral stenosis. Let's go through the step beyond question. What heart sound represents the left atrium contracting into a stiff, non-compliant ventricle? So the LA contracting into a very stiff, non-compliant ventricle, that's going to be S4. That's going to be a late diastolic sound. Which of the following changes would be noted? A patient presents to the emergency department after collapsing in the garage. Vital signs show saturations of 100% on room air. The patient is noted to have cherry red skin. Which of the following changes would be noted? Carboxyhemoglobin, methemoglobin, and P-AO2 are going to be your parameters. So in this question, you are going to be worried about carbon monoxide poisoning. Carbon monoxide poisoning is going to have a normal pulse oximetry because the pulse ox cannot tell the difference between carboxyhemoglobin as well as oxyhemoglobin. So your carboxyhemoglobin is going to be normal. Remember, this is not methemoglobinemia, and this only changes the saturations on hemoglobin. It doesn't change your P-AO2, i.e. the amount you dissolve. Because carbon monoxide has a higher affinity than oxygen on the hemoiety, it only changes your saturation. So the best answer here is going to be D, high carboxy, normal PaO2, and methemoglobin. All right. This is an arrow question testing you on carbon monoxide poisoning. Watch for cherry red skin, elevated carbon monoxide levels with normal PaO2. Step beyond question here is going to be, what biochemical process does carbon monoxide and cyanide inhibit? Think to yourself. It's going to be the electron transport chain, specifically complex 4 in the electron transport chain. And that's why these patients, especially with cyanide poisoning, are going to have lactic acidosis, because if you shut down electron transport chain, you're not going to have aerobic metabolism, you're going to have anaerobic metabolism. All that pyruvate can't go down TCA and electron transport chain. The pyruvate shunts into lactate. All right, we are down to our last 3 questions. Which of the following abnormalities would be expected in a patient who presents with bilateral hydronephrosis? A, spinal cord abnormality. B, kidney stone in the left ureter. C, ureteropelvic junction obstruction. Or D, ureteral canalization failure. What do you think is the best answer here? So in somebody with bilateral hydronephrosis, you have to be thinking about somewhere lower in the urinary tract. And so if you're thinking about spinal cord, let's say if you have spina bifida, meningocele, myelomeningocele, where you have disruption of your pudendal nerve, for example, you're going to get what we call a neurogenic bladder, a bladder that is not going to have any tone and inability to empty the urine. If you can't empty the urine, well, all of that urine is going to back pressure into the ureters bilaterally and is going to cause bilateral hydronephrosis. So the best answer here is going to be A. All 3 choices, B, C, and D, cause unilateral hydronephrosis. A kidney stone doesn't cause bilateral. Typically, it's going to be a unilateral hydronephrosis. So this is testing you on hydronephrosis. Note that if you're thinking bilateral hydronephrosis, it has to be down. And remember, other questions we're talking about prostate. This was a little bit of a spaced repetition talking to you about how the bladder is also part of that lower urinary tract system. So what amniotic fluid values would be abnormal in myelomeningocele? So that's the herniation of the dura and the spinal cord. You're going to be thinking particularly of AFP and acetylcholinesterase. Which of the following pathology mechanisms is noted in this patient? A 22-year-old female presents with infertility. She has dyspareunia. The patient has normal period intervals. However, her menses are marked with severe lower abdominal pain and heavy bleeding for 7 days. The pelvic ultrasound shows normal female internal structures. Which of the following pathology mechanisms is noted in this patient? A, cyst formation, B, myometrial proliferation, C, smooth muscle hyperplasia, D, ectopic tissue, or E, physiologic normal menses. Well, in this situation, when you think about infertility with cyclical abdominal pain, heavy menses, and pain during sexual intercourse, you're going to be thinking about the diagnosis of endometriosis. And endometriosis is going to be ectopic endometrial tissue. Sometimes it's going to end up kind of posting up in the posterior fornix. And because it's in the ectopic areas, you end up having severe cyclical abdominal pain. And that's kind of the key when it comes to endometriosis. So endometriosis, watch for cyclical abdominal pain, heavy menses, and infertility. The step beyond question here is, what gross pathology finding would you note in a patient with endometriosis of the ovary? And this one has been seen on many NBMEs. That's the chocolate ovary, okay? So endometriosis that is going to implant in the ovary, you're going to be thinking of the chocolate ovary on gross pathology. All right, this is one of our last questions of the day. A male presents with a UTI. It is noted that a malformation of the urethral folds is present in the patient. Which of the following defects is likely contributing to this patient's UTI? A, bifid scrotum, B, cryptorchidism, C, epispadias, D, hypospadias, E, patent processus vaginalis. So the malformation in the urethral folds, that is key. And remember, that means that the ventral surface of the penis does not fuse properly. And that is very classic for hypospadias. Remember, the epispadias is the failure or malposition of the genital tubercle. Going into the important points, this is an embryology question testing you on hypospadias. It's important to contrast that with epispadias like we just did. It is a failure of fusion of urethral folds. And the step beyond question is the following. What do the urethral folds develop into in the female, i.e. urethral folds in the male, ventral surface of the penis, urethral folds in the female, that's going to be the labia minora. Remember, the labioscrotal swellings are going to be labio majora, whereas labia minora is the urethral folds. All right. we have come to the finish line today. Which of the following pathophysiologic mechanisms is most likely going to be seen in this patient? A 59-year-old female presents with progressive fatigue. She is noted to have a history of hypothyroidism. Vital signs are 37.2, 100 beats per minute, respirations of 15, and blood pressure 100/80. Laboratory studies are noted for a low hemoglobin and an MCV of 114. Serum sodium is noted to be decreased as well. Which of the following pathophysiologic mechanisms most likely is noted in this patient? A, autoimmune destruction of parietal cells. B, upregulation of RAS. C, chronic inflammation leading to anemia of chronic disease. Or D, decreased dietary folate. Awesome. So in this situation, you note that the patient has an autoimmune stigmata. She has hypothyroidism. This points to a little bit of adrenal insufficiency with the fatigue. So whenever you're thinking autoimmune plus macrocytic anemia, i.e. with the low hemoglobin and a high MCV, you should be thinking of the common megaloblastic anemia, which is going to be pernicious anemia. And pernicious anemia is an autoimmune destruction of the parietal cells, which secrete intrinsic factor. So just to tie in, parietal cells have two types of functions that you need to know for your exam. Number one, it is going to increase acid in the gut, i.e. in the stomach. And number two, it's going to secrete intrinsic factor. Remember, pantoprazole or any prazole medications are going to be proton pump inhibitors that are going to inhibit the active transport, i.e. the acid production from the parietal cells. So remember, fatigue, autoimmune, macrocytic anemia, you're going to be thinking primarily of megaloblastic anemia. This patient doesn't have any intrinsic factor. That means no B12. And that's what contributes to your hypersegmented neutrophils that you'll see on your microscopic pathology. So an increase in what metabolite produces neuro deficits in B12 deficiency? And that is going to be an increase in methylmalonic acid. And please go into my biochemistry section of my pass-fail course and know the mechanism behind why increase methylmalonic acid. In short, you can't take propionyl-CoA from fatty acid oxidation and make it into succinyl-CoA in the TCA cycle because you have a B12 deficiency. MMA goes up. Methylmalonic acid is toxic to the nerves, and that's why I have neurodeficits in B12, and that's different than your exam questions related to folate deficiencies. All right, everybody. I really appreciate your time. Remember, if you're a medical student eager to excel on the USMLE in an efficient, engaging manner, which of the following resources may optimize you as a student? Well, actually, I think that it is going to be all of the above, including HyGuru. So hopefully you have your UFAPs down, but you also add a little HY, high yield UFAPs, into the mix. And that is where my pass-fail course really is going to help you as you go into your preparation. In all seriousness, though, I just want to thank you guys for attending. You guys have been absolutely awesome. I know we did go a little bit over, but again, it's just my blind passion wanting to make sure that I give you a comprehensive review. We went through 40 questions today and really would love to see you in the pass-fail course. It's about 70 hours, just added micro. I'm going to be adding neuroanatomy upcoming as well. You're going to go through all 10 organ systems in an integrated way. There are going to be very short videos. As you can see, they're like 2 minutes, 5 minutes. Some are a little bit longer, but I try to keep them short. And there are some customized UWorld questions as well as flashcards that you can use. So my pass-fail course allows for you to incorporate UWorld into your studies as well as high-yield vignette style flashcards that are going to have test-taking tips. Speaking of test-taking tips, if you really want to improve on your NBMEs as well as the UWorld blocks, you should really go into my test-taking strategies course. It helps for both step 1 and step 2. It gives you a study schedule, how to be productive. It really brings you to the next level at a very low cost, because I know everybody can't necessarily do tutoring just from time and financial limitations. That's totally fine. That's why I kind of put private tutoring into one course right here, and that is going to be the test-taking strategies course. The test-taking strategies course has the similar question breakdowns, but goes more into test-taking strategy, how to review USMLE blocks, etc. So I would definitely check it out, and it comes with that free Notion study schedule. And if you like today's session, please Google HyGuru Trustpilot and just leave a honest review if you really enjoyed this session. I would love if you could share HyGuru on social media when you're watching my YouTube videos. Even when you come across some unique questions, just tag me. I'd love to highlight you, because it is you, the student community, that really elevates me as an educator and keeps me passionate with this. So look forward to seeing you in other organ systems review. And before you leave, if you don't mind just typing one thing you learned in the chat box, I would love to hear what your retention was, and we'll go ahead and end the session today with the live Q&A. I'll stick around, but otherwise, if you don't have any questions, feel free to log off the webinar. Thanks again, and look forward to seeing you in the next session. You guys are great.